Well, dear colleagues, it's most certainly my pleasure to welcome you to this Meet the Experts ASV session. My name is Holger Wörle from Ulm, Germany, and we want to have a expert session here with key parts of the CERVHF steering committee and Professor Jean-Louis Pepin to talk about, what's the current situation with ASV. 1 year ago, we presented the results of the CERVHF trial, which were surprising to everybody, at the ERS conference. And in the meantime, we tried to gather new information by performing more analysis, but also looking beyond what's there in this largest randomized controlled trial, looking into new ways of analyzing what we could do with ASV and where it might be helpful in sleep medicine. So we also want to give you a first insight into work that we're currently doing with an expert board in big data. So we're going to have presentation first of the key results that we analyzed in the last year with the CERVHF trial. It's going to be presented by different members of the steering committee. Then we're going to have some insight into this new project with big data around ASV, and then we hope to have an intense discussion around our findings and what you think about it, and how we can proceed with our future clinical use of adaptive ventilation. This session is recorded, so when you have a question during the question and answers, please stand up, get a microphone, and tell us who you are, so we can put you on tape, and give us your best looks, of course. So we want to start off with the presentation, and there it is. I want to quickly, that's the agenda. So the intro, that was it. We're going to do CERVHF. We're going to talk more about ASV use and benefits, and then we'll look into the new project. And I'll hand over the flipper to Professor Martin Cowie, the co-PI of the CERVHF trial.
Thank you very much, Holger. So as Holger said, I'm Martin Cowie. I'm Professor of Cardiology at Imperial College in London, and it was my pleasure to help co-lead with Helmut Tescher beside me this randomized trial. Now, I didn't choose this slide. I don't perceive that CERVHF is actually a failure. It was actually a very robust attempt to address a very important clinical question. Didn't give us the answer we expected, but actually that's very important, and I think the science has moved on a lot even in the last 12 months. So just to remind you of what we were trying to do. As you're all aware, ASV is a very clever algorithm that can control central sleep apnea, and particularly Cheyne-Stokes, very well, and considerably better than CPAP. And there's lots of evidence from small trials and observational data that patients with that who were treated with ASV did better, and meta-analysis strongly suggested a positive outcome for that. So there were some people that suggested we didn't need to do a randomized trial. There was sufficient evidence, and lots of people had already started to practice in that way. I think the cardiovascular community was less convinced and particularly wanted an adequately powered outcome study with hard endpoints such as mortality, cardiovascular outcome. So that's why CERVHF was set up, and congratulations and thanks to Resmed for stepping up to the plate, as the Americans say, and funding this proper assessment of the technology. And the result was published in the New England Journal of Medicine just about a year ago, as you know, so it was of interest to the clinical community. So what we wanted to do very simply was just test the hypothesis. Does in patients with reduced ejection fraction heart failure and good going central sleep apnea, if you randomize them to ASV compared to usual care, do you improve the outcome for patients? And this was the primary outcome in the study, as you know, just to remind you. So this is the intention to treat analysis. So this is the one that's protected from bias by the randomization. And we found no effect overall on our primary endpoint, which was all-cause mortality, life-saving cardiovascular intervention, such as heart transplant, LVAD implant, or life-saving shock from your device, or unplanned hospitalization and heart failure. So, neutral study. What was unexpected completely, and of course caused some consternation amongst the regulators and change in the usage of this technology, is shown on this slide. So on the left-hand side, this is a component of the primary endpoint, all-cause mortality, and you can see here that there was a 28% increase in deaths in our trial for patients randomized to ASV. If you look at cardiovascular mortality, of course, the effect size is larger, as you might expect, and here it's 34% increase in cardiovascular mortality, and very unlikely to be due to chance. So this was a surprise finding, and the rest of the presentations, I think, will drill down into the data a little bit more to see if we can get some mechanistic understanding of where this toxicity might come from. Thank you.
Thank you. And as Martin said, this was an interesting finding, to say the very least. And when the New England Journal paper was published, there were editorials, there was a lot of clinical feedback and comment, probably from people such as yourself, raising questions as to, was this really a true finding, bearing in mind the previous meta-analysis, the other previous controlled trials? And some of the issues people raised are, what about the adherence? Did people actually use the treatment? What about crossovers? Were there many crossovers? And so a further, very robust analysis was carried out using Cox-cause-specific hazard methods. And this is a schematic indicating the kind of considerations that need to be taken into account. Blue bars there equal people who are in the control group, and the red indicates people who are on ASV. But of course, individual subjects, as they go through the trial, can behave in a variety of ways. The bottom two, as you can see there, are people who, on the blue bar, who were randomized to control, who then continued on control throughout the study. And then the red bar above it, people randomized to ASV, continued with ASV throughout the study. But not everyone does that. The most robust analysis is intention to treat, but you can see the dotted lines there. For example, a dotted blue line is someone randomized to control who then has some ASV use. And likewise, a dotted red line is someone who's randomized to ASV, but actually doesn't use the treatment, discontinues it. And so, having done the intention to treat analysis, two more analyses were done. Firstly, an on-treatment analysis, which is simply looking at those who used ASV throughout the trial, those who were in the control group throughout the trial. The difficulty with that is that it introduces a number of biases in terms of those who don't want to use the treatment, or those in the control group who decide they want to use the treatment. And people can swap over, cross over early, and we define that was within the first 2 weeks, or they can cross over late on, and that's indicated in the top group of bars because, as I say, the on-treatment analysis introduces bias, but the best way to minimize that bias is to use an as-treated, as-randomized analysis, and therefore you know which people who are randomized to that particular limb actually continue and for what periods of time in that limb. So that's one of the further important analysis that has been done. Next slide, please. And you can see at the top chart there, forest plots, you can see control, then you can see intention to treat, demonstrating the hazard ratio, that the ASV was harmful to patients. The as-treated group is the one, as I mentioned, that could introduce the bias, and therefore there wasn't a major hazard effect. But the more robust as-treated, as-randomized analysis shows a very similar effect in terms of hazard ratio to the intention to treat analysis. And therefore, I think from that one can be reasonably certain that the original finding is a correct finding, and ASV did cause those hard endpoints of harm. The second point to take into account is the compliance, and people very reasonably said, well, is it the fact that if people use more ASV they came to more harm, no ASV they came to less harm? But you can see there didn't seem to be a dose-dependent effect using the hazard ratio as an outcome. So in summary, the further analysis backs up the original finding.
Thank you very much. So after seeing that, so the as we just mentioned, the original, I have to shift there. The original SURVEY-HF subgroup analysis so indicated that the mortality risk was greatest in patients with central sleep apnea with particularly low ventricular ejection fraction. So to go further, this was a univariate analysis, and we performed what is called a multi-state multivariate analysis for those of you who are interested in statistics, I recommend very strongly to go to the paper that has been published online in the Lancet Respiratory Medicine a couple of days ago. I'm not going to explain that in details, but basically that relies on a sort of analysis of the different components of the primary endpoint. So, because the initial result was univariate, non-adjusted, and analyzed only, this reanalysis is extremely important to support the first finding and also to give insight into the potential mechanism that might be responsible. If you look at the result here, you can see that actually it is extremely clear that there is a mortality risk which is increased with the low ventricular ejection fraction. So this statistical relationship between the mortality risk and the patient's left ventricular ejection fraction is confirmed, the risk being greatest in those with the lowest ejection fraction, as you can see. So that is a way to confirm that the mortality risk is indeed increased in patients with left ventricular ejection fraction below 45, and that the harmful effect of ASV correlates well with pre-existing left ventricular systolic impairments. And actually there were no other variables that were found to be independently correlated with the risk of sudden death. Now, if we go in detail in this analysis, as you can see, it's clear that one of the mechanisms that has been suggested and which is confirmed by this analysis is also the fact that it's correlated with, to some extent, it suggests that sudden death is the major circumstances where death occurs in these patients. The reason for that being that there is no actually increase in the hospitalization for aggravation of ventricular failure. And just to give you a look to what actually we're looking for, as you see, these are the patients that were actually looked at, and as you can see, there are some of them that have life-saving event, 166. Yeah. So that this is this. There are 428 that were admitted to hospital for a worsening heart failure, and as a result, 357 died for cardiovascular events and 68 died from non-cardiovascular events. So the tested variables were implantable cardioverter defibrillator at baseline, the baseline ventricular ejection fraction, and also the baseline Cheyne-Stokes respiration. And there is also a correlation with the baseline Cheyne-Stokes respiration above 50%. So the conclusion is that we can, from this analysis, confirm that the mortality is present in those patients under ASV that have a low ejection fraction and a severe ventricular failure. Excuse me. Go ahead.
So, having established that the increased mortality seen in the SERVE-HF study is genuine and not an artifact, the next question was to whether the ASV would increase left ventricular from dysfunction. And thanks to the design of the study, we have a sub-study asking especially this question. So the sub-study included 300 patients from the SERVE-HF main study, and this study demonstrated that the use of ASV did not induce a significant decrease in LVEF, and neither changes other biological markers of heart dysfunction. Considering the rate of hospitalization, the rate of hospitalization due to ASV was not increased during the study, not increased in the ASV group compared to the control group. We can conclude that the observed effect of mortality is not a sort of toxic effect of ASV, definitely not. So the next question was whether whether the mortality could be a consequence of the pressure applied by the machine. And that has been analyzed as well, and I think that Helmut knows the
answer.
the answer.
Helmut always knows.
Sorry. Maybe it's out of order. So what this here shows you is, sorry, yeah. What this shows you is that the mortality risk seen in the SURF heart failure is unrelated to the magnitude of positive airway pressure delivered. And you see this for the different pressures delivered in the SURF heart failure study. Can I have that, please? I'm sorry, I have the, where is this? Okay, yeah. So in summary, ASV does not affect left ventricular function, and remodeling of the systemic markers associated with heart failure syndrome, this is on the left side. There's also no meaningful increase in hospitalization to worsening of heart failure. That's the middle part of that slide. And the risk bears no relation to the magnitude of the inspiratory positive pressure delivered to the individual patient. I hope I'm now in order. So what we can conclude then is that adaptive servo ventilation is not in itself a procedure that puts patients at risk, and this is true irrespective of the individual usage pattern of the patient and the pressure magnitude which has been chosen. ASV is therefore harmful only in the presence of significant left ventricular dysfunction, and people with enlarged and weakened left ventricles are a distinct and particular vulnerable group, of course, some of whom may also be at risk of sudden cardiac death from coexisting arrhythmias. And as we all know in current clinical practice, this has led to the increasing use of ICDs. Patients with normal left ventricular function continue to be eligible for the use of adaptive servo ventilation. The mortality risk observed in the SURF heart failure trial was seen in a high-risk group, as mentioned several times, characterized by systolic heart failure and predominant central sleep apnea. The at-risk group is not representative of all patients who may be eligible for ASV therapy. Informed by these findings, experts in the field agree that patients with left ventricular ejection fraction above 45 remain eligible for ASV treatment whenever there is a clinical rationale for doing this. And this also includes both European and US academic authorities. You see these labels here. So what can we now conclude, and how do we understand the existing risk? The mortality risks observed in the SURF heart failure trial has been confirmed as a true clinical finding. The mortality risk was seen only in patients with systolic heart failure and predominant central sleep apnea. We know from the sub-study that adaptive servo-ventilation does not worsen left ventricular function, and the mortality risk appears to be unrelated to the positive pressure that has been applied. Of course, reduced ejection fraction should always be excluded before we start adaptive servo-ventilation, and finally, patients with normal left ventricular function continue to be eligible for this kind of treatment. I guess it's not working.
So, in summary, what we did in the last years, we focused on all the different questions that were raised by the different editorials, comments. Overall, there were 12 publications in different journals highlighting what kind of analysis researchers would be interested to see. As the faculty presented to you, key questions were the compliance analysis or treatment analysis that we've done. The other one was no more in terms of mechanisms of death, which Patrick presented, which is this multi-state modeling. And tomorrow, strangely, in the latest update of the thoracic surgery, there's actually the presentation of this multi-state model, which was published 2 days ago by Christine Eulenburg, who was the statistician who performed it. So tomorrow at 10:45 in that session, you can get a deep insight into the multi-state modeling, and tomorrow at 12:45 there will be a poster on more extensive where you can see all the pressure analysis that we've done. In addition, we're constantly working still with the data. Marie-Pia has shown you some insight into our major sub-study where we wanted to initially investigate mechanisms, how we improve outcomes, and now we're trying to find mechanisms we know how we can explain the outcome. And we're continuing to harvesting that data. Patrick and Jean-Louis led a core lab that analyzed now all the PSG data of the trial, which we're going to hopefully present within the next year. And so we're still committed in harvesting that data and looking at that data and giving us more understanding of why do we have this unexpected result, and why might central sleep apnea in severe systolic heart failure be different to other phenotypes that we see, for example, in opioid patients or in patients with classical complex sleep apnea in the absence of heart failure. And we're also still interested later in the discussion to get suggestions, you know, to what to look at and to what we could do, what people are still interested in. I think we're trying to answer the first set of questions that were raised in all of the publications and all of the discussions at the conferences. But now, having discussed cerebral ejection, we're going to go into a deeper discussion at the end of this session. We have a long session for Q&A. We also want to talk now, you know, where's currently the use and benefit of ASV, and I'd like to invite Marie-Pia and Anita to talk about where are we now with these results clinically with ASV.
Thank you, Holger. As we all know, we've been using ASV to treat central sleep apnea outside, also outside the specific case of heart failure with low ejection fraction. And there is many situations where we can observe central sleep apnea, and we all know them. It's central sleep apnea in neurological context, especially after stroke. We also have central sleep apnea induced by drugs, especially opioids, but not only. We've seen that, and we've published that with Jean-Louis and Frédéric on baclofen, also on sodium oxybate, etc. So there's many situations where we have some patients with central sleep apnea, also in heart failure patients with preserved ejection fraction, and sometimes we do not find any etiology, and it's idiopathic central sleep apnea. And we're also facing some patients who developed central sleep apnea being put on CPAP for obstructive sleep apnea, the well-known COMP-SAF, and also patients with mixed sleep apnea, where probably ASV can be a good answer. And we have several papers, and we're going to see in the following slides. There has been works on published paper on each of these situations. For example, in patients with COMPSAS, ASV has been compared to CPAP in a randomized study, and in an intention to treat analysis, ASV was more efficient than CPAP in normalizing HI below 10 or even below 5. And as you can see, to completely normalize HI, ASV is definitely more efficient than CPAP. In patients with mixed sleep apnea, we also have a randomized study comparing ASV to CPAP. And as you can see, after 30 days of treatment, ASV does better definitely than CPAP on HI, on central sleep apnea index. Also, it does better in improving sleep, as you can see on the micro-arousal index, and definitely it does improve the sleepiness as measured by the Epworth sleepiness scale. Regarding heart failure patients with preserved ejection fraction, we have in France a registry, the FEST registry, and if you want to go to have more detailed results, Renaud Tamizier is presenting tomorrow at the poster session at 12:45 the results. But the main results are there, I would say. In the registry, we have enrolled over the last year some heart failure patients with either low ejection fraction or preserved ejection, reduced ejection fraction or preserved ejection fraction. And you can see all the patients on this graph, the Kaplan-Meier. You have in red the low ejection fraction, the reduced ejection fraction, treated with ASV, and the low ejection fraction not treated. And the green and the black is patient with preserved ejection fraction. And the Kaplan-Meier curve suggests that the heart failure patient with preserved ejection fraction do better than the other when they are treated by ASV. And we have no safety signal in this group of patients, definitely. We also have data from the CAT-HF study, which was a prospective randomized heart failure study in which patients with either HFrEF or HFpEF were randomized to have either ASV plus optimized medical treatment or versus the control group who has optimized medical treatment. And this study was interrupted after the SURVEY-HF because it included patients with low ejection fraction patients, so the study has to be stopped. But we have the subgroup of HFpEF, and in this subgroup, they seem to do better when they are treated with ASV. As you can see here, there is a reduction in the hazard ratio, a significant reduction in the hazard ratio of outcome. So it's a small group, but definitely we have to work more on HFpEF to go on with to strengthen all these results.
So two more pieces to add to the jigsaw. Firstly, there's a growing interest, I think, in opioid-induced sleep-disordered breathing, and opioid-induced central sleep apnea is more common than I think was previously expected. And of course, there's an epidemic of prescription of opioid drugs, particularly in the USA. This is a trial that is a small one. It's a prospective randomized crossover study, which I think adds some clinical information, although one must bear in mind it's small, and it's a comparison of ASV with bilevel non-invasive ventilation. That's a question that's often asked, why not use standard NIV? Intuitively, that's not a terribly good idea because most of these patients are normocapnic or hypocapnic. But this comparison actually shows that compared to bilevel non-invasive ventilation in ST mode, so there's a backup rate, ASV was more effective in controlling central apneas, in overall apnea index, and also respiratory arousal index. And interestingly, as you can see from the comment at the end, there is those respiratory variables, central apneas, overall apnea index, was normalised in over 80% of patients, but only a third of patients who were using bi-level spontaneous time non-invasive ventilation. So I think increasing interest in that particular group. And then another retrospective study, which and Catherine Brill in this study had 154 patients on ASV, and then took a subgroup who had sustained CVAs, they had ischemic stroke, and had central sleep apnea as a result of that CVA. And she looked at the efficacy of ASV in that group. So it was a very simple retrospective study, but actually showed significant improvement. Many of those patients had actually tried CPAP and were crossed over. And as well as improvement in apnea-hypopnea index, patients reported improvements in their sleepiness and also their alertness during the day. So I think more work needs to be done in this area, but it's suggesting for those of us who are clinicians who are faced with these patients at the moment that this is a possibility. The important thing to say, though, is if we're moving on to consider ASV, bearing in mind what we've heard, we should exclude left ventricular failure, and that these patients should have been assessed. We need to understand that they have not got an ejection fraction that's equal or less than 45%, and that may involve getting an echocardiogram or even a cardiology review. Thank you.
Yeah, so we wanted to give also an overview of, that we didn't stop doing ASV research just because one trial didn't work out in the way it does, but I personally think in 5 to 10 years we're going to even use more ASV than we currently do, but in different indications. I'm going to start on the bottom because as a sleep physician also, not just a respiratory physician, I think ASV will be in 5 to 10 years a clinical tool for us to optimize sleep, to treat either insomnia or hypersomnia in patients who are treated for OSA with CPAP. And we shouldn't forget, we've got, for example, at least 5% of our patients we treat the best we can with CPAP or with APAP, and we treat the PLMs and whatever we have, they stay hypersomnic. And there's early data that when you optimize their sleep with ASV, where you can reduce arousal, hypersomnia gets better. And there's Dr. Krakow from the US, who does research in OSA patients who have insomnia, and he puts them from CPAP on ASV, and we're sponsoring a trial with him. We can see that sleep actually gets better. So I think in the future, just to give you an outlook, is we're going to see ASV being used as a clinical tool rather as a sleep stabilizer than just an AHI metric to come down. But as especially also Maria Pia presented, heart failure with preserved ejection fraction is a different thing than heart failure with reduced ejection fraction, which we can also see in terms of the treatment, because while heart failure with reduced ejection fraction, there's 7 guideline medications, there's implanted devices, there's lots of things. In heart failure with preserved ejection fraction, we're still looking for any intervention that can improve outcomes. And the first data that we've done in the US looks quite positive that here might be something for ASV, and we're sponsoring another trial which is done in Sweden, where they look at heart failure with preserved ejection fraction and optimizing risk factors, and one of the key risk factors is sleep apnea. Yeah, same thing is being done right now in Norway with atrial fibrillation. Yeah, and Michael Arzt, who's here in the audience, is performing a trial with using ASV after acute myocardial infarction, where we know that's a very vulnerable period where we can either improve the heart or we can get heart failure patients. So I think still there's a lot of areas in cardiology for ASV to be explored. In addition, of course, we would like to see more data. And that's why we're launching a registry in Europe with ASV, because there's different clinical practices in different countries. We know that. But everybody has seen some positive effects in different categories of patients, and I think we need to collect that data to be able to discuss then, where are other good areas to trial with ASV in sleep. Yeah, and I think that's why we need to collect more of that data. And in addition, our French colleagues have I think a great initiative where they do together with the regulators, which I think is always great to do an initiative together, where they do a multi-manufacturer, multi-center registry also on the use of ASV. So I think we're going to get more data that will help us to understand where the clinical use is, and I think it's going to go in quite a widespread field, because central sleep apnea covers many different phenotypes. And I think the future of modern medicine is rather with precision medicine phenotyping the problem of the patient and finding the right intervention. Yeah, and that's, I think, where ASV will be helpful for all different sorts of challenges that we're facing in respiratory sleep medicine. So first of all, thanks to all the speakers for their presentation, and especially for staying in time, which is not very common at this conference often. So thank you very much. And now we want to open it for a discussion. You know, we presented you data on SERVE-HF. So we presented you data on compliance, on trying to find mechanisms around it. You know, why do we see the results that we see? We presented you what other areas are where ASV is being used. And Jean-Louis presented some very interesting look in, I think, what's the new field of medicine into analyzing more data, like big data. And so you've got the expert group here, and I invite you to get a microphone and ask some serious questions. Yeah. I knew that nobody would jump to the microphone. It's always the same. Although I really invited you cordially. You know, I did my best that I could, but I knew that. So, since we have a cardiologist here, Martin, perhaps, you know, we heard that about, you know, ASV and the sub-study not changing, as you always say, the heart failure syndrome. And on the other hand, you know, we've got this new insight with the multi-state modeling, with this kind of like, I call it the direct route to death, where the first event is really a death. Could you put those results, perhaps again from a cardiologist's point of view, into a clinical context, you know, about when we think about what could be the detrimental mechanism, you know, for this intervention in this select group?
Well, I think the multi-state model is actually hugely helpful to understand what might be going on. And a lot of people initially seemed to be thinking it was a direct pressure toxic effect on a failing ventricle, and that was why it was damaging it. What was against that theory, of course, was that patients didn't seem to have an increased risk of heart failure hospitalization, which you would expect if it was a direct pressure effect on the ventricle. And we also saw in the sub-study, which is a very detailed MRI, echo, every peptide you've ever heard of was in that sub-study, and not a single signal that there was any change in the heart failure syndrome per se. No change in left or right ventricular function from 0 to 12 months at least, and no change of any of the peptides that reflect either cardiac strain like BNP, or systemic inflammation, or renal function. So all of that was kind of building a story that was against a pressure effect. Helmut's shown you the analysis, as we have in the poster, looking at the pressures applied by the ASV, and it doesn't matter how you cut it, it doesn't seem to be associated with the hazard. So that leaves us then really with the arrhythmic sudden death, or presumed arrhythmic exit of these patients. And this is where the multi-state model is very useful, because of all the events that occurred. And remember, the curves in the New England Journal are just timed to first event. Here in the multi-state model, we can look at all of the events that happened to patients and also the route to those events. So did you have a hospitalization first and then die? Did you have a hospitalization, then an ICD shock, and then die, for example? And putting it all together, very, very strong signal. The hazard ratio is 5 point something for the low ejection fraction patient. So a 5-fold increased risk of not decompensating your heart failure, but just disappearing suddenly. Presumably a cardiac cause, presumably arrhythmic. Hazard ratio 5 point something for the lowest ejection fraction. If you had a defibrillator, it partially protected you. Certainly was a strong effect there. If you didn't have a defibrillator, I don't want to tell you what the hazard ratio estimate is. It's really astronomical. So all of this is building a story that by getting rid probably of the chain Stokes rather than other forms of central sleep apnea, you reset the arrhythmic risk for these patients. And they weren't just dying in the middle of the night with a mask attached to them. They died throughout the 24-hour period. So I think it's something about the entrainment of the cardiac, respiratory, endocrine rhythms centrally to give you chain Stokes. Yes, it's a marker of risk in a very damaged ventricle heart failure patient, but actually it's being developed by the body to damp down the arrhythmic potential. If you get rid of the chain Stokes, it seems to be that that risk increases astronomically. How often do you see a hazard ratio of 5.2 in an intervention study? So I think that's where the story is at the moment. We've still got the defib data to look at, but I'm afraid a lot of patients who died didn't have their device interrogated after their death. So it may give us a clue or it may not, but the multi-state model strongly suggests it's tachyarrhythmia that is the potential for harm. So that's where the story is now. I think the cardiology community thinks it's very interesting, but are slightly distanced from it because they weren't the people mostly putting the ASV therapy on patients. What's interests me, and maybe we'll have it in the discussion, is that lots of respiratory physicians say, but my patient comes back and says, I feel better, which I think is fantastic. We also had that effect in our control group as well, coming back and saying, thank you, I feel much better. And of course, you don't come back if you die suddenly. So they don't come back to tell you that they felt better. So I think it's quite a complex thing, but I think the recommendations here of please make sure the patient doesn't have a low ejection fraction. It's very simple, it's very pragmatic, and protects patients from being exposed to risk while we sort out the mechanisms. Sorry, it was a very long answer. I can give short answers as well.
Holger,
Yeah.
a question to the cardiologist. You underline the importance to make sure that the patient does not have a low ejection fraction. But would you recommend to do systematic echo in a patient who doesn't have any history of cardiovascular event whatsoever?
Well, echo is actually not that complex or expensive an investigation. And if you're going to put somebody on a therapy lifelong thereafter, I actually would say I think it's sensible to get an echocardiogram. Unless you're working in a healthcare environment where that is just not going to happen, or the patient's going to have to wait years. But I think most people here represent societies where echo is quite easy to get, and here's a strong indication. So I know where you're trying to push me, but I'm going to push back slightly and say it's not complex. Please make sure of that. Very low risk patients, I suppose, if they were very young and they were using opiates for back pain and it was related to that. But I think I'd feel more comfortable having an echocardiogram, so if something did happen to the patient, at least you could defend your practice very robustly. Whereas if you don't do that, there's always that element of doubt. I have to say, just one thing to, is it light in the tone? I'm not sure, but I presented the data somewhere, and a physician from a European country stood up and said, well, I'm still going to go and do exactly the same because my patients come back and say, I feel better. And I said to him, well, I could give you a long scientific answer, but actually the shortest answer is I should be a lawyer in your city. So I think it's really important that we think about risk stratification, the appropriate patient group, what is the phenotype, and then, of course, if it's appropriate, go straight ahead.
Thank you, Joaquin Duran from Spain. I appreciate the effort, especially for looking new horizont. But in general, the results are disappointing, and not only for Serve. 1 week ago, in New England Journal was published the SAFE results, and finally, CPAP don't protect for cardiovascular event. And my question is, what is how is going to look from authorities? Authorities of National Health Service probably is going to look CPAP as not an important treatment. So it shows we are worried, because what can you do? What is going to be the future, the next future?
So while we're lining up, just so that everybody's aboard, last week at the European Society of Cardiology, the SAFE study led by Dr. McAvoy and team was presented. It's an international trial that looked at high cardiovascular risk patients, did a randomized trial with 2,700 patients, CPAP versus nothing, and the result is neutral. So there was no reduction overall. Their compliance in an OSA trial was 3.3 hours. So although they were lower and less disease, they had a lower compliance. But it's a great question, Joachim, and maybe Patrick can start.
Well, I think to be the only actually positive result in that study is actually there is an improvement in sleepiness and quality of life, which of course has been known in that sort of patient for the last decades, I would say. To be honest, I think one reason for, and that's probably a sort of strategic issue for the next years, is that the two populations that were targeted in these two studies were actually very sick. I mean, this is a secondary prevention study, so meaning that they targeted patients that already had a cardiovascular disease to see whether there was an improvement with CPAP. So that was not an easy population, and I think to some extent, of course, this is completely different in terms of patients, but that's to some extent what also occurred to SERVE-HF, because that was also a very sick population. So I don't know how the authorities are going to interpret that. Of course, if they still they stay on the issue that there is no effect or a deleterious effect, that's going to be a problem. On the other end, but we all know that it's also difficult. We should probably target other populations that might be more responsive or less sick. But as you know, it's also an issue because then the probability of having a positive answer is not that high.
Joachim, can I add some comments? In the SAFE study, there is also a signal regarding the reduction in the absenteeism at work. So we absolutely need some cost-effectiveness studies regarding CPAP. I think it's really important. The second point is we should admit as a respiratory physician that CPAP should be combined with an aggressive risk management, including other factors than CPAP. I am sure you remember the paper in the New England Journal of Medicine of Chirinos showing that there is a synergistic effect between weight loss and CPAP. And I think it's also the good way to address this question and to convince the health authorities. For example, in Grenoble, we have different randomized control trials comparing CPAP alone versus CPAP plus physical activity. And in this situation, you can get both the improvement in quality of life and sleepiness, and also probably an additional factor to other risk factors management.
Helmut also wanted to give a quick comment, and then we're off to the next question.
I'm not 100% sure, but I believe they excluded patients with very significant desaturation during the night.
Yep.
This is point number one, and I believe it is important having Dr. Oldenburg's data in mind. Point number two is I believe telemedicine could help to improve compliance in this situation, and I guess the situation or the data would look different if that would be the case. It's only speculation, but I believe it is important.
Next question.
My name is Anne Gabrielsen. I'm a pulmonologist in Norway. And thank you so much for doing those sub-studies. Because when it comes to the bottom line, now I think I can give my patients with the normal heart and complex sleep apnea, ASV modus, without any kind of bad feelings. But there is still one little question.
Sure.
Do I have to take them through CPAP first if they have a complex sleep apnea, or can I go directly to ASV?
Let's look who's got the highest. No, it's also interesting because Jean-Louis presented some data that at least hint into I'll start off, okay, and then we'll see what the others say because I'm the most conflicted one, okay. But if we look at the data that Jean-Louis presented, it's actually interesting to monitor it under CPAP if it's a complex one, because we've seen there is transient one, but there is also emergent one, which we would miss if we don't monitor it. And I think that's why I think it's fair to start with CPAP, if the patient tolerates it. We shouldn't forget in those patients, it's a database. So if US practices that they move them directly to ASV, it's not in the database because they start with a different device. But in this database of CPAP patients, it's worth monitoring because some goes away, but in others it emerges. And I think the emergent ones we would currently miss with most clinical practice because we wouldn't look into it. So I think that's my statement. Let's see if the others kill me for that.
I would like to add how long on ASV. if the patient is on ASV, should he stay on ASV forever, or should we retest after several months? And I would prefer a device which allows to switch between different modes to find out what is best for that particular person long term, at which time. In half the patients I'm treating, I'm seeing this feature goes away after several months and he is fine on fixed or auto CPAP. This is my personal belief and experience.
I think it's really important to monitor trajectories because we have very easy to look tools with information regarding residual RHI. It's very simple to look at the different trajectories during several weeks and to decide at the end. If I remember in the ERS statement for complex sleep apnea, the recommendation is first CPAP during several weeks and then ASV.
It's also related to the definition, of course, of complex sleep.
Yes, but by definition you have CPAP first, yeah.
Classify the patient as complex.
But maybe, you know, since we heard about it, and thank you, Johan, for that comment, but also maybe you can comment, when will you publish it? Will it be published in the next couple of weeks, your
The paper
statement?
is accepted last week.
Okay,
So
Perfect.
I guess this year.
perfect. No, that's great. It's good. I mean, it helps, you know, it helps. We shouldn't forget there's lots of people out there looking for statements like that to help them guide their clinical practice. Sure, Marie-Pia.
Can I would add some comments. Of course, by definition, COMSAS is first on CPAP, then on ASV. And regarding other central sleep apnea, having this data in mind that if the patient keep a high HI on CPAP, he has a greater risk of low compliance and even drop-off. I would go first for ASV to give the most chance to the higher chance to the patient. So.
Peter was first. Yeah.
I have a question about this ejection fraction 45% because I'm sometimes having some trouble with it. As an example, a patient was referred to our clinic a couple of weeks ago and was the last echo being made in December 2015. Was having ejection fraction 47%. Patient is coming to my office and said, well, maybe it's a bit long ago, echo, so I need a new echo. And then I found an ejection fraction 43%. It's tough for me because the cardiologists tell me that there is some range and when they do an echo. So what will you do in such a kind of patient with a 43 as a last assessment?
So you're absolutely right. All biological measurements of variation in ejection fraction is very wide variation, particularly if it's not a very tightly controlled lab or detailed study. I think you have to think about the phenotype of the patient and what you're trying to achieve therapeutically. All guidelines have cut points, which are pretty artificial. So I think guidelines are fine, but ultimately it's your responsibility as a physician to weigh up risk and benefit and think what you're trying to achieve. It's unlikely your heart failure patient with that ejection fraction is terribly sleepy during the day, because as you know, heart failure protects you from sleepiness to a large extent. So in my own practice, if the patient's not sleepy during the day, I don't go looking to try and apply these therapies. If this patient doesn't have heart failure and all you're quantifying is an ejection fraction, then really the issue disappears, and really it's a different question. So I'm afraid the guidelines don't give up the thing that you have to think about the patient in front of you, which I'm sure you do.
I do, yeah. It's another question. Can I continue, Holger?
Yeah,
Is it
sure.
okay? So when you look at now the data for the patient with preserved ejection fraction, it seems that ASV might be beneficial. And in fact, we had the same feeling a couple of years ago when the patient had all these studies, or when the studies being done in the patient with a reduced ejection fraction. So the answer or the conclusion of ASV, the SURF-HF study disappointed us a lot. So I think now we think that patients with preserved ejection fraction might be good candidates. In my view, another RCT in this group of patients is needed. What's your opinion of Resmed for it?
Well, I can start with that, and then, you know, but that's the data that we presented are an early phase 2A trial, you know, which was a combination of REF and PEF patients, which was a hospital-based trial in the US. And the other program that we're supporting in Sweden right now is also a phase 2B trial, you know. So I think, of course, in the future we'll need in those indications randomized controlled trials. But what we did in CERVIGF is we jumped from phase 1 trials to phase 3, which is often being done right now in pharma, yeah, where you need mortality outcomes. But I think as we learn here, I mean, respiratory medicine is a domain of making people feel better. And that's in many different areas. In all the COPD studies we will hear here about different pharmaceutical interventions, there is no improvement in mortality, but we improve patients' lives. That's what we do as pulmonologists and quality of life. And so that's why I think, you know, in the future, we have to do after our phase 1 studies, phase 2A or phase 2B studies, we have to consider also safety. And but I think those could be important results to drive the future use of ASV, and especially heart failure with preserved ejection fraction seems to be a good target, because also there is nothing right now available. And also, if you think about the pathophysiology of the disease, I think sleep disorder breathing could be a contributor to disease progression. So, but yeah, we have to trial it, and we're doing it. That's why we showed you the portfolio of clinical research. You wanted to say something, Sean?
No, I agree.
Yeah. Olav, you wanted to, can somebody?
I think we are here to just look into the near future and the midterm future. And I totally agree with Helmuth. What he said is we have to think a little bit outside the box, or maybe inside the box. As what we have learned from CAT-HF is, in acute phase, sleep disorder breathing might be very different compared to the following weeks. And also what we have seen from your data is that we have a shift from obstructive to central and back and forth. So there might be the need to monitor sleep while we treat it, and that we probably have to change therapy modes within treatment. So we probably need more monitoring and different algorithm to treat sleep disorder breathing. For example, so if we have a patient acutely decompensated, I'm talking about heart failure, of course, acute decompensated, we put him on CPAP and we see central sleep apnea is emerging over time, that should be an alarm signal to see his cardiologist, on the one hand. On the other hand, I'm not sure if we should not treat some mixed sleep apnea in an acute setting. Why not? As long as the central events fade away during the next weeks, that's fine. So I leave the reimbursement to you guys, so how to do that. But I think the more intelligent devices with more telemonitoring might be one idea for the future.
It's interesting. So monitoring comes up quite a lot, and I think something that has not this year come up in discussion. I think last year, you know, we were quite in a hard position with our compliance figures, where we had CERVIGF at 3.6 hours on average, which we found pretty good as the steering committee of the trial, but nobody else liked it. This year, SAFE has 3.3 hours, and so it shows probably that for the future, we need different support mechanisms to improve compliance into an area where we think our interventions are beneficial. What do you think, Patrick, Murray, Pia, Anita, Helmut, the respiratory side?
Well, I think it's obvious. I mean, I don't think we can be satisfied with the 3.3 hours of CPAP per day. I mean, all the studies that have been done before suggest that it's largely insufficient. Whether we can interpret that in the context of the SAFE study is another issue. So for sure, well, there are two issues there. One is support education, and that's also question how the authorities, at least in Europe, want to do. If they want to use the device as something which is the device only, or if any support is included in what is supported by the authorities. The other thing is what I could say as telemedicine and all the issue of any of the technique that might enable us to support that and to support the use of the device. And I think that's critical. That's absolutely critical.
And in particular, the very early use, establishing people on therapy, ensuring that they can cope with it, that you're controlling the events. I think one badly needs that information.
Yeah. I think, as Patrick and Anita have underlined already, I think a key question is a close follow-up of the patient. And now we have, with the telecompliance, the telemedicine, all the tools to follow up very closely our patient, both in terms of AHI normalization and in terms of compliance. So, and it's really the 2-day treatment to follow the patient on a daily basis. Of course, we cannot follow our patient on a daily basis, but then we can add some machine learning on the top to detect special alarm to detect some patient at risk of either getting rid of the treatment or at risk of any acute event. And maybe you can comment on that.
No, I fully agree with you and Olaf. I think we need a very innovative continuous monitoring of this patient, because it's ridiculous to have the same reimbursement for people immediately at 8 hours compliance every night. So we have first to describe different trajectories in huge data set to better understand different phenotypes, and then to apply different treatment strategy. As Patrick said just before, we can now implement around the CPAP device some connected device, some additional measurements, some coaching, some etc. But it's ridiculous to implement such a complex strategy to all the patients. And by doing a close monitoring during the first week, we can decide it's okay for this patient. In this one, we have to implement some telephone calls, for example, and this one is probably impossible to achieve a significant compliance. So it's just the beginning of precision medicine in sleep apnea.
So what is Martin's opinion on that? Because a week ago he was the undertaker for telemedicine in cardiology.
I was staying very quiet for very good reasons. So my general take on it is, I think where technology makes sense to give you more information to make better decisions, surely it's worth demonstrating the added value. I'm afraid in my study with implanted devices, looking at lots and lots of data every week didn't make a difference compared to usual. But it sounds to me it's a very different scenario. You're intervening with a new therapy. That initial period is very crucial. Is it the right therapy? How compliant is the patient? And so remote monitoring for that period, probably quite short, maybe be hugely helpful. But of course, maybe you have to be brave enough and prove that.
In the real world situation, I still believe we are not only talking about algorithms, we have good algorithms, we are also talking about how to deal with these patients during the first weeks and months. And my personal belief is we need telemonitoring during that time. It helps a lot to identify patients which do have problems, for example, with leak. And then to do more with these patients to fix the problem. And industry has to come up with better mask solutions as well. It's not only the algorithm which matters, my personal belief, it's also what we can get, for example, for stopping leak, for managing these patients during the first 3 or 4 months. If the patient then is on the device, he will stay on the device. And my belief is this makes also a big difference. There's a lot to do, and telemedicine, once again, also he's the undertaker, helps during this period of time.
So it's an interesting, just to summarize that, and you know, to perhaps shed light on some other aspects of the presentation, is we have a telemonitoring, or for telehealth, which I like to call it, which is not just a monitoring. It's so we have in one part it's important to monitor. Yeah, that's what I think comes from the discussion here, to really also phenotype the patient correctly, because if we phenotype them correctly, we can find the appropriate therapy. Number 2, it seems, especially in the at-risk populations that were studied recently, telehealth can help to promote appropriate use of devices and appropriate compliance, which, I mean, there's some work lately that shows that maybe the REM phases in the early morning are important, that the patients still use their mask and don't take them off when they go to the bathroom in the early morning. But number 3 is an important point, which is telehealth outside of just mask management. Of course, potentially sleep disorders itself, lead to a sedentary behavior. We know that when we treat patients with CPAP, they rather gain weight than lose weight. We want them to lose weight, but actually they rather gain a little bit of weight. And maybe we need to use that intervention to also work on an aspect outside of just treating apnea, but treating the apnea syndrome with the associated lifestyle.
Yeah, I think that's exactly the point. It's interesting for those of us who actually know the history from not the very beginning, but at least has spent 30 years, the last 30 years to study and practice in this field. That it took 30 years to understand that it was not only the fact that we should put a CPAP, we should first check that it was correctly used, and second, probably do something else than CPAP. And that makes sense. So now what we have to implement is both the phenotyping that you mentioned and also strategy and of course the device is critical in that context, but not only the device, the fact that we have to take into account the comorbidities and treat them. And we have to know that probably, at least regarding cardiovascular outcomes, CPAP is not sufficient. We have to do more than that.
Let's also take one step back, and I mean, we tried to give you some insights today in what we did in the last year, with the available data that we have from SERVICE-F, and we also tried to give you some insights on where we think, currently the field is for those different phenotypes where we have opportunities to treat. And a colleague from Norway kindly, shared her comment on, how she sees that data. But we would like to get, this group here worked very hard last year trying to help understand those data. Is it helpful what we presented today? Does it help your clinical practice?
It's totally useless.
But I want other people to tell you it was useless what you presented, not just me, So you see, we didn't lose our good, our good vibes around the trial, although the result. But so what do people think about the results? Does it help? Is this next level of information helpful to get an idea of why we saw those unexpected results? Are people kind of like happy with that, or would you like to see different things? And also, where do you think are other unmet needs? With ASV use. I mean, we discussed that we're doing work in PEF and in atrial fibrillation, but we know that most people are coming from complex sleep apnea. We shared with you that we're going to do more registries to collect data. So yeah, can we go from telemonitoring back to ASV a little bit and discuss, on the one hand, where are we with the science? Is that okay? Is that helpful? On the other hand, what's with ASV clinical use? How do you leave the conference? What do you do with it, clinically and scientifically?
Are you less disappointed? That's the point. No, they're not less disappointed.
No, you're allowed to still be disappointed, but you must be more enlightened with the results, kind of.
I think the overview was very useful, but I've still the feeling that there is some underestimation of the periodicity, the periodic briefing in the patients, and that this is not well scored, and therefore this could have an impact on the outcome of the patients. So I think it would be useful to also score the time spent in Gens-Ox breathing.
Absolutely. No, it's a very important point, Johan. And so, first of all, I mean, what we established with the multi-state modeling that Patrick presented, I think it's a way to characterize the risk and then look also at other parameters. I think we agree as a group that we looked at it rather in a crude way now with having those categories of Cheyne-Stokes respiration of 20 to 50 and more than 50%. What we can share with you is that a colleague of mine with his group developed an algorithm now to phenotype Cheyne-Stokes respiration automatically. Okay, so to get periodicity, cycle lengths, and all of that. And Jean-Louis and team did an analysis of all the sub-study PSGs with a core lab. And the next, now after we've established this multi-state model, is to look at certain respiratory phenotypes that's on our to-do list and see if that influences it. So far, we have to say all respiratory variables always lost any significance, when we took into models left ventricular ejection fraction. That seems to overpower kind of like the respiratory phenotype, but we agree we want to do a more, a finer analysis of respiratory variables and then redo the analysis. Is that a fair statement, Patrick?
That's okay. I think, of course, we are all interested in having a sort of potential mechanism, despite the fact that, okay, it's autonomic nervous system, but having said that, so if that could be a marker, that would be extremely interesting. It's very clear that from what has been published until now in the New England Journal or the multi-state that we presented, there is no detailed analysis of chain-soak respiration, as Olga said. So we can expect that it might have some insight from this detailed analysis.
I know many people here in the room. I can't believe that you don't have any question, you know? Some of you are going to attend the Resmed research dinner tonight. You're just going to get a glass of water if you don't ask a question. I can tell you. Sure. Fernando wants a glass of wine tonight.
Well, it's a comment about the telemedicine use, no? I think now we are starting with the telemonitoring, but probably we can move the telemonitoring to telehealth.
Yeah.
That is, probably we must include in this telemonitoring telehealth appropriate control, better control of the comorbidities like hypertension, diabetes, and dyslipidemia, and also, and very important, diet and exercise. I think that the technology is available for that. Probably these ways to reduce the cardiovascular event can produce together the final reduction of the cardiovascular, increasing the CPAP use, increasing the exercise, decrease weight, and also better control of the comorbidities.
Actually, it's a great comment because it goes into the direction, you know, what we were discussing, I think, the last 5 to 10 years with PEP treatment overall. We don't treat the PSG, we treat the patient, yeah? And so it shows more and more that AHI reduction is one important factor, you know, but it's not the only one. And that's why, yeah, I think telehealth is a great opportunity as an example. Michael also. I knew
He wants wine.
I knew Michael wants an espresso tonight. Decaffeinated.
Michael asked Regensburg, Germany, so I apologize, I cannot attend the research dinner tonight. So it's not for the wine, and the reason why I waited so long, because the question might be so difficult.
Oh.
So you performed the as treatment and as treatment as randomized analysis. And on a first sight, the as treatment analysis shows that ASV has a hazard ratio below 1 and seems to be protective. But the obviously better as treated as randomized analysis has again the same or similar hazard ratio like the intentional treat analysis. Could you maybe expand the explanation of the difference of the as treated and as treated as randomized analysis?
I'll try first, and I'll hope I'll get some help, because it's, yeah. I tried to explain it at the ATS, and I know that people, I think 10% left the room said I might have understood what you told us. So I'll try to get 20% today. What we learned is that those patients who stop therapy, allocated therapy in the different groups, are different patient groups, okay? So when you take those patients in the control group who cross over to a therapy, you have to think about the setting. It's a patient who is in a randomized trial, who gets allocated to control and somewhat gets the randomized treatment. He must either be himself very active with his disease, or he must have a physician who is very concerned about him, yeah? So those were, when we compare those patients, those were the patients with the lower risk who went from the control group to treatment. If you look at the patient group who stopped treatment, especially early in the ASV group, those were patients with very high risk, okay? So patients who were old and had the most severe heart failure who just couldn't use the device anymore. So when you take out those patients from the two groups, that's how you bias the result. You make the control group worse by taking out the best patients, and you make the therapy group better by taking out the worst patients. And that's how suddenly that result becomes neutral, yeah? But that's just because of a selection bias, yeah? And that's why I think, you know, we have to be cautious with normal on-treatment analysis because, yeah, I think what we learned through this trial is that usage of a device also means more than just using a device. It's also associated with health behavior, but also with disease state. And that's why I think we need to make those robust analyses to really identify if it's a mechanism or not, the treatment. Is that
It's very
agreeable? Did I reach 20%? Yeah, no, go ahead.
Michael is still...
Michael is still. No, yeah. No, we'll go first, go.
Please. Arnaud Prigent from France. I would like to know if the patient who used nasal mask had the same mortality than the others.
We did a crude look at masks, and we didn't find a signal, okay? But again, while we're pretty cautious with cherry-picking populations is that, again, even a mask choice reflects a different group. If you can, the more elderly, more severe patients with more hyperventilation had more use of full-face masks. So we didn't see a signal, but those groups are also different, yeah?
Well over 70% used full face masks,
yes.
didn't they? It was quite a small subgroup that used nasal masks.
Nasal mask, yeah. Yeah. Michael, one more? We're happy. Is it now a more difficult question?
No.
It's a second glass of wine.
No, so I was very happy with the first answer. So I try another one. So you also performed this interesting analysis of the stratification in different LVHF groups, and the question is how to convince authorities that the risk stops at LVF of 45. So when looking at the data, all hazard ratios were above 1. And in the, I think in the 36 to 45 group, at least the confidence interval crossed the 1. So how can we proceed to really define what is the safe area to use ASV?
Anybody else? Me wants to comment? Well, I'll start. You know, because
Holger, you're not the regulator, so I'm not sure you can address the question. But you have had discussions with the regulator. The scientific community, as you know, has said we only give strong statements where there's evidence base, and then they leave it where we don't have a strong evidence base, so it is unknown. The physician has to decide what's appropriate. So, for example, the heart failure guidelines are very specific about the 45% cut point, but they do not give an opinion above that. But you know what the regulator's done with it.
Here, what we shouldn't forget is this analysis that you're looking at is not something where we're trying to refine the risk to a certain group. You know, we were very clear, and all the regulators agreed when the results came out that there is a risk and it should be contraindicated in this population below. This analysis is just within our risk population trying to identify the mechanisms of harm, okay? And surprisingly, we found this linear correlation with impairment of left ventricular ejection fraction. We thought, you know, maybe it's also Cheyne-Stokes as an example, yeah? So that's why we can't talk about anything with this data about what's above 45%. What speaks to it in the discussion with the regulator is that, as Martin said, you know, the hazards are very high for low ejection fraction, especially without the use of an ICD, which speaks to a sudden cardiac death risk, which is something that's very prevalent in low ejection heart failure, but not in the general population. So that's why the regulator so far agreed that the use above 45 is okay, but hence the scientific activities that we showed you to provide more data, more insight into these other populations. It's very important. Well, I want to say, because we're at the end in terms of time, I also want to say a big thank you to Resmed, because most companies who have a negative trial close the books. And you won't see any other publication from a negative trial. You see 20 positive from a positive, but not from a negative. But negative trials help us to, through the scientific results, to work on new endeavors in research, but also to help us understand better our clinical care. So I think I want to give it, also from the steering committee, as we always did, a big thank you that we could continue to harvest this database and to help with presenting such data, that we can optimize our clinical care and also get new ideas for research. And on the other hand, I want to thank the steering committee and Jean-Lee for this session, and also for the continuous work to help us understand CERVHF data better, and with that to take better care of our patients. And I think we got lots of new ideas today about especially connected care, precision medicine, and also telehealth, that we can further improve our patients' lives with sleep disorder breathing. If you're interested in the slides, you can get a summary of the slides. Just come up to the Resmed booth, leave us your email address. We're happy to share information. Also, if you have additional questions, come and see us. I want to thank you all for attending, and wish you a great ERS conference, and hope to see you soon again. Thank you very much.